This is a genetic disorder. The sad thing about this is, although there are two forms, there's a dominant and the recessive. The more common type is the dominant. The sad thing about it is you're born with it, right? But you don't manifest the symptoms until you're in your 30s. You could be growing up normal, making plans. So let's say Miss Lacklot, married in her 20s, and then she had no idea he has this genetic disorder. She already has children, young kids. She's an RN. She's working, she got a great career. She took her master's. Now she's working on her PhD. Plans of a bright future. Okay. And then this hits her. One day she develops manifestations of acute kidney injury, right? And then she's admitted to the hospital, and then they do tests, they do a CAT scan, they'll see multiple cysts on her kidneys, on one or both kidneys. Let me show you what the cysts look like. Maybe there's a picture here. There's not, so let me show you a picture. It's not pretty. So what happens is the patient develops this in your 30s. Okay, no manifestations, no indication, unless you have a history, and then they'll screen you. So let's say your parents have it, or one or both parents have the disorder. Then in that case, yeah, you're high risk for, this is what your kidneys look like inside. Gives you goosebumps, right? I mean, makes you scratchy. Look at that. The kidneys are now filled with cysts. And this is a large a kidney. Okay, so your kidney enlarges, makes it twice or sometimes bigger than double the size. And they're filled with these fluid-filled cysts. The cysts eventually rupture and they leave holes in the kidney. But basically, is this kidney functioning? Not if it's filled with cysts. Okay, so the patient develops the first symptom would be acute kidney injury. And then after one admission, then the patient's now aware. They will go home. There's no treatment, sadly. We can it's all conservative, meaning symptomatic treatment. Was there treatment for CKD?
No.
Was there medicine you can take that will cure CKD? No. What was the only treatment? Supportive, right? Mainly supportive, meaning you avoid any other substances or food or medications that will hurt the kidneys more, right? So conservative treatment, so the treatment for it is conservative treatment, supportive treatment, just like how you treat chronic kidney disease. There are other manifestations though besides CKD. Besides CKD. So once the kidneys are now all destroyed, so now the patient has CKD. Until then, though, these are the manifestations. So I won't repeat CKD. We did that on module 1. So a patient will have signs and symptoms of chronic kidney disease. So fluid overload, hypertension, what else? They'll have calcium imbalances, right? Can they have anemia? Yes, all the manifestations of CKD. In addition to that, the patient will also have blood in the urine. The patient can have stones, kidney stones, so that causes pain, right? Then those stones will, of course, cause UTIs, proteinuria, pain, back pain. The patient, once the cysts grow so big, they can obstruct the bowel. So patient will have some bowel obstruction here, constipation. So it's going to be a long road, okay, a long journey for this patient. They won't die today. Okay? They will have CKD, and if the patient gets lucky, they'll receive a kidney transplant, and that's about it. Okay, so genetic testing again, is done if the imaging, meaning CAT scan, MRI, is not very conclusive, then they'll do genetic testing. Or if the patient has a family history, so let's say Caroline knows her parents, my parents had PKD, and she's concerned, so her primary doctor can opt in her 30s. They can do, not even in your 30s, they can do a genetic testing. Okay, so they'll do genetic testing to see if you have the predisposition, so that at least you can prepare. But then there's ethical considerations there. Would you really want to know? Right? So that's another issue. Okay, so you have, yes, your parents have PKD. Do you really want to find out if you have it? Okay, so I mean, it's up to the patient. Okay, that's all I'm saying. I mean, some patients, yeah, I'd like to know, but some, I don't think. Sadly, there's none. There's no treatment, so it won't make a difference. Okay, although you can prepare, right? You can plan ahead. You can get maybe plus, of course. Remember, the insurance company, will they take you with a pre-existing condition? No, so that's another issue you have to consider, right? Because now we know you have PKD. You know you have PKD. Are you still insurable? I mean, life insurance wise, health insurance, okay. We have Obamacare, okay. They can't deny you for pre-existing conditions anymore. But life insurance is another issue. Okay, they have not regulated that part of life insurance. Okay, no one will insure you. Oh, you have PKD. We're not insuring you. We know you're gonna die prematurely. Okay. So again, no cure. So all the treatment is supportive. How we treat CKD, the same thing. If we get to dialysis, then you'll go into dialysis. Pain medications, yes, that'll be part because there's flank pain here. You'll get UTIs repeatedly because of the stones that you'll be developing regularly. So it's a sad, anything else you need to know? It's something, you can't have no control over either. It's genetic, yes.
So, okay, let's say someone gets a new kid.
Uh-huh.
They can still get this.
No, because that's from your kidneys. So this one, yeah, once you get a transplant, that's no longer your kidneys. So they should be fine. That's it for on chapter 48. We'll go to 49 now. Let's review.
That was fun.
Said that at the beginning. It's short.
Everybody went over it.
Okay, so for 49, let's start with pyelonephritis. Let's just go down the list. So let's do acute and chronic pyelonephritis. What is acute pyelonephritis? So this is basically an infection of the kidneys. Most cases is caused or predisposed. I mean, this is a consequence of a UTI, meaning 9 out of 10 patients who have acute pyelonephritis had a UTI first. And obviously, was the UTI either treated or not? Not treated, or maybe not diagnosed. And then the infection went up. It went from the lower urinary tract to the bladder, now went up to the ureters and then infected the kidneys. Or in some small percentage, the infection may not have started from the lower urinary tract. It could have been started from the blood and then reached the kidneys. But that's a very rare case. Most cases came from a lower urinary tract infection, which was obviously either untreated or undertreated. Patients stopped taking the antibiotics because they felt better, okay, and then the infection got worse. Abscesses may form, meaning you'll have pus in the kidneys in some cases, especially if not caught early. Now, who are at risk for this? Knowing what the sequence is and what gender. Okay, so same as those high risk for UTI, then you're high risk for this. So women, if you're the type, because are all UTI symptomatic? No, that's another issue which can lead to acute pyelonephritis. So, and who are moms here? Okay, so moms, what do? Are you always concerned about a UTI? No, you get these symptoms, you usually blow it off, right? And then now, next thing you know, you have the flank pain. Okay, let's go to the manifestations now. So here are the pain now. So it includes signs and symptoms of a UTI, plus now you have evidence of a kidney infection. So now the retroperitoneal area is now tender. So when we touch your flank area, it's painful. Okay, it involves fever, of course, high fevers. You'll have pus in the urine, Okay, here, pain and tenderness in the costovertebral angle. That's your retroperitoneum. And again, signs and symptoms of a UTI. Yes. Well, once it reaches the kidney, yes, but the UTI is the longest period, meaning, yeah, because you have normal flora there. So with the UTI, you may go on without symptoms at all with the UTI, unless the women, the patients are very, self-conscious or are aware of their own body. But otherwise, no. The only way we can diagnose it is a CAT scan. We have to see the kidneys, and kidneys will show enlargement, inflammation. Then that's your evidence of the pyelonephritis. They can do this test. What is IVP? IV pyelogram. So this uses a dye though. Now, usually, if you have a pyelonephritis, so is there kidney damage already?
Yes.
Okay, so is your creatinine level already elevated?
Yes.
What will happen if they do this test, which uses a dye, and there's evidence of, okay, so, but the doctor needs it done though. So what should be done before they go to the test? Fluids. Okay, so fluids, and then they will also be given, what is that drug again we used to treat Tylenol toxicity? Acetylcysteine. Okay, so that will be administered to protect your kidneys. Okay, they'll be giving that by mouth, and then lots of fluids, and then when the doctor's satisfied with that, we'll send you for the test. But it's important for you to know your responsibilities. Okay, don't just go sending the patient to the CAT scan right away. Always look at for IVP, always look at kidney function first. Management, because this is an acute infection. So what's the treatment? Antibiotics. Okay. This will always involve IV antibiotics, or if the patient is caught early, they may only receive one IV antibiotic, usually in the ER, and then they'll be sent home, meaning if they don't have complications. Okay, so that's what it says here. If it's an acute uncomplicated pyelonephritis, meaning the patient doesn't show signs of sepsis. What is sepsis again? A systemic blood infection. So if it still says acute pyelonephritis on the CAT scan, patient shows no evidence of sepsis, they can be treated outpatient. They'll definitely get one IV antibiotic dose in the ER and then send you home on oral. But you need to follow up, of course, periodically, and the patient will have to have a follow-up blood test to make sure it cleared the infection. For complicated cases of pyelonephritis, meaning the patient is septic, we'll discuss sepsis next semester. That will be your first module for in January. And of course, what's the most common event that preceded the pyelonephritis? A UTI. So that's another reason why the patient is on antibiotics. So part of your teaching, will it include signs and symptoms of a UTI? Will you include that? Yes, because can this happen again? Yes. And then while inpatient or even outpatient, we encourage, how did we treat UTIs again? And what else? What do you teach the patient to do? Hydration. Okay, so oral hydration at home or IV hydration if you're admitted. Any question on acute pyelonephritis? That's it. Okay, let's go to chronic now. The problem with chronic is, look at, we can see the manifestations as well. We can compare. So you saw manifestations of acute pyelonephritis. Basically, what are they signs and symptoms of? An infection, correct? Okay, so let's go to chronic. Before we look at the cause, let's look at the manifestations. What are the manifestations of for chronic pyelonephritis? CKD. Is there an evidence of infection here? Not at all. So therefore, let's look at the causes. So what causes chronic pyelonephritis? Since the manifestations show no evidence of an infection. So is this caused by a UTI? No. So what are the causes? Causes. So what's the cause of chronic pyelonephritis? Okay, so let's look at the first statement. So repeated bouts of acute pyelonephritis may lead to chronic pyelonephritis. Now, in the first place, how did they get repeated bouts of acute? So do these patients have a normal anatomy? No, these patients usually have something wrong with their anatomy. Why are you having frequent bouts of, because you know what causes acute pyelonephritis? A UTI. So that means what did they have frequently? UTIs. So why do you have frequent UTIs? It's not, we're gonna go beyond, it couldn't be that you don't wash. Okay, that let's say the patient's just really nasty, just don't wash, no concept of hygiene. It can't be that. There must be something else wrong with your anatomy down in your pelvis. Okay, so usually this is caused by some physiologic anatomy anomaly. So let's say there's a fistula. Okay, we had no idea that there's a connection. There's a small tube connecting your bladder and your bowel, for instance. Or let's say your vagina, your vaginal canal, your vaginal canal is connected somehow to your bladder. Okay, so there's something anatomically wrong. So usually when patients have chronic pyelonephritis, they send them for testing, extensive testing around the pelvis, ultrasounds, CAT scans. We want to see why are you having frequent acute bouts of acute pyelonephritis. All right, that's usually the testing. Complications, of course, of chronic pyelonephritis is chronic kidney disease. And we're not repeating again CKD. You already know the management. So here it is. If the patient does have evidence of those anatomical problems, then they'll put them on prophylactic antibiotics. Okay, so just to decrease the number of repeated infections. And if there's a surgical option to repair a fistula or whatever is the anatomical problem, then they'll do that. Any questions? That's it for chronic pyelonephritis. Let's go to UTIs now. So we did, okay. Start with risk factors. So who gets UTIs? Okay. All right, so here we are, chart 49-1. Gender, diabetes, pregnancy, neurologic disorders such as stroke. You know, something that will impair bladder function. Have you heard of a neurogenic bladder? You know, stroke patients usually have that, meaning the signal, or spinal cord injury patients also, meaning the bladder doesn't respond to brain control anymore. Okay, it can't contract, meaning can the patient pee independently? No. So they need to be catheterized in order to pee. Gout, and then again, any condition that will cause urinary stasis, meaning urinary retention. Okay, you're not able to empty your bladder. So the longer urine sits in the bladder, then bacteria grows, UTI develops. Or immunosuppression, and these anatomical problems here. Okay, so any obstruction of urine flow. What profession will you add here? Okay, truck drivers, nurses, who else? Yeah, nurses, who else? Yeah, it's particularly nurses because yeah, it's hard for us to take a break because if you leave the floor, something happens to your patient, can that be abandonment? Yes, although you didn't intend to, right? So meaning even if you go to the bathroom, you have to tell somebody. So that's the nature of our and job description. Okay, we're it. Okay, we can't leave the floor without endorsing your patient. So let's say you're starving, right? You need to go get something to eat. So you can't leave the floor. Okay? You need to smoke, right? You're a smoker. Yeah, I gotta smoke. You still need to leave your patients with somebody. Let's go straight to the manifestation. So all I'm testing is the, because on the blueprint, it says here for UTIs, here we know pathophysiology, signs and symptoms, and then straight to interventions. Okay, we didn't have to do the specific causes. Okay, so we did the risk factors, and then now signs and symptoms. No two UTI patients will look alike, especially if we're talking about the elderly. Will elderly be expected to manifest the same as any other patient? No. Okay. I won't read it for you. Please read the manifestations. Can this be a good select all that apply? Okay, your favorites. Okay. Let's pause for a minute for CAUTI, CAUTI. You will be required to do documentation of your, we have a bundle for CAUTI. CAUTI is catheter-associated urinary tract infections, right? So therefore, what's causing this thing? A catheter, an indwelling catheter. Now, if you remember from when you discussed surgical patients last semester, that would be last semester. Did you go discuss SCIP, SCIP? Did you come across that? Okay, so SCIP is a Surgical Care Improvement Project. That's one of the core measures for the Joint Commission. What are core measures? Core measures are standards, meaning Joint Commission publishes the core measures. And let's say you're a new hospital and you want to be accredited by the Joint Commission, right? So you apply for accreditation, and the criteria is you have to meet the core measures. They publish their core measures on the website, meaning these are minimum standards that must be followed by all Joint Commission candidates. So if you want to be accredited, make sure you follow all the core measures. So one of the core measures, and they have core measures for everything: pneumonia, stroke, heart failure, diabetes, COPD, surgical patients, trauma patients, stroke patients. So they all have core measures. They have standards, meaning for every one of those diagnoses, you must do these. You must provide these. Is that clear? Yeah. It's simple, really. It's black and white. So if you want Joint Commission seal on your door, just prove that you meet the core measures. Okay, that they don't ask much. Okay, just show us the evidence that you do meet the core measures. So for surgical patients, core measure is 48 hours. Foley catheter must not be in longer than 48 hours. Do Foley catheters stay more than 48 hours? Of course, but there must be justifiable reason, meaning the doctor has to document why is this Foley still in after 2 days. Are we clear? Meaning there has to be a reason. Why is it still there? Because why did Joint Commission do that? Because of this, because of CAUTI, because of CAUTI. Evidence shows that if a catheter stays more than 48 hours in a person, it will cause or increase the risk of a UTI. Okay. So we'll look at the indications. It'll be on a separate page, but we'll look at CAUTI prevention and also the indication. So regarding 48 hours, so if you put the Foley in, keep the Foley in for longer than 48 hours, what are those indications? Okay, so that you know as a nurse that, oh, okay, my patient meets the indication why the Foley is still in after 2 days. All right. So on, because that's common in practice. So every time you document on Epic, why the patient has a Foley, because Epic will automatically give you a pop-up message and it will not go away unless you address it. So the moment the patient's Foley is older than 48 hours, the message will pop up. Every time you open this patient's chart, that big yellow box will pop up. Patient has a Foley catheter. And then it will ask you to, did you notify the physician? Okay, what is the indication why it's in there? Okay, it will always pop up. Why? Because of this. So can patients die from a COTI? Yes, it can lead to sepsis here, urosepsis. And then once we discuss sepsis next semester, so you'll see how serious sepsis is and why it has a high mortality. And what is the average age of patients who have Foley catheters? Actually, elderly. Okay, and then they are high risk for sepsis as well. Right. Of course, we have young people who get catheters, but they have lesser risk for sepsis, or they have higher survival rate. So besides age, gender, okay, we already talked about risk factors. Chart 49-1. So here are others: neurogenic bladder, we mentioned that. Okay, females, diabetics, right? What else? Patients who are incontinent, or patients who have any cause that leads to urinary retention. Okay. So here are specifically risk factors for the adult. So we had general risk factors, chart 49-1. This one are risk factors, chart 49-2, for the elderly. So when we say older adults, what age is this? 65 or older. So these are the characteristics of older adults that make them at risk for frequent UTIs. The organisms, we typically, because we have to start antibiotics right away, depends on the patient's picture or where did this patient live. So let's say it's an institutionalized patient, meaning in a long-term care facility. So we already know the causative organisms there is usually E. coli, right? And in hospitalized patients, we have organism resistant, antibiotic resistant strains if they get it from the hospital. So these are the manifestations again. Antibiotics are given, should be given early, unless of course the patient has evidence of sepsis, then we follow a different sequence. Okay, I'll discuss sepsis bundle when we do that next semester. So cultures must be drawn before you start the antibiotics. So you get a urine sample before you start the antibiotic therapy. And fluids, of course, it will be given. For antibiotics, so we've got common antibiotics here, which we use for almost all all cases of UTI, unless the patient shows evidence of sepsis. These are the, again, we don't decide the length of the therapy, whether it's 3-day course, which is usually prescribed for uncomplicated UTIs, but for complicated UTIs, it's 7 to 10 days, up to 2 weeks of therapy. So here, if it's it's common in women, right? So they can do either one-time IV administration or oral for 3 days. Okay, so these are for uncomplicated cases, but for complicated ones, they can go either 7 days, 10 days, or 2 weeks. All right, here are the common medications. Table 49-1. So it doesn't matter the age of the patient or gender. A UTI is a UTI. These are the commonly prescribed antibiotics. Patient has allergies to one, they'll use another one. Okay, but these are the choices. You'll notice that these are all antibiotics except the last one. The last one is not an antibiotic. It's a urinary analgesic, phenazopyridine, brand name Pyridium. This is for symptomatic treatment only because UTIs cause burning, correct? Causes bladder spasm. So this is the purpose of prescribing phenazopyridine. Are we clear? Is this an antibiotic? It is not an antibiotic. Side effect, it turns your urine orange. Okay. All the rest of the drugs mentioned here are antibiotics. The patient may be on one. Sometimes the doctor, especially if it's a complicated UTI, they'll prescribe two. Are we clear? Okay, but again, that's not our decision. But these are, we need to know what common antibiotics are used for UTI. At least with this table, there are no listed side effects. So that's one thing less you need to study. Okay, you're lucky. The other edition, chapter edition, textbook edition had listed side effects. So you had more to be tested on. All right, let's go now to the, like I mentioned, the nursing care, of course, besides antibiotics, what do you tell the patient to do? Increase fluids, what else?
Hygiene.
Okay, so let's talk about hygiene. So when should they wash the perineum, especially females? When? Every 10 days? Oh, every what? Okay, after using the bathroom, only that? Okay, front to back, wipe from front to back. Is it front to back or back to front?
No, front to back.
I go back to front.
Because you don't have to worry about
it. Regarding sexual activity.
Right.
Yes.
Okay, before and after. Okay, so urinate after intercourse, but when do you wash? Okay, before and after. Okay, just making sure because I had a student before long ago, and she argued with me that they should only wash after sexual, and she was like very. I can't drop names. Okay? All right, so please read the rest. Let's say on relieving pain. So who knows about cranberry supplements here and cranberry juice? Okay. You take them too? Anyone here? Females taking cranberry supplements?
No, I don't take cranberry supplements, but I drink cranberry juice.
Okay, all right. So here are the teachings, okay? So I grabbed a few questions from here. What do you encourage them to drink? What do you encourage them to avoid drinking? Okay, so they're all here. Again, they're on the paragraphs. Okay, so you've got their coffee, tea, citrus, spices, colas, alcohol. And here's your general teaching. So somebody said the hydration, shower rather than bathe. Okay, front to back, wiping, fluid intake. Here are the beverages to avoid. Okay, frequent voiding or what voiding habits to promote. Yeah, this one did say after, okay, immediately after penile vaginal intercourse. So does that mean before is optional?
No.
Yes. Okay. Let me just find the indications. Maybe it's on the next page. Okay, right here. Urinary catheters. All right, so who gets a urinary catheter and when can they be justified for use over 48 hours? When we say 48 hours, though, you don't have to keep it for 48 hours. You can terminate, you can discontinue the Foley anytime the patient no longer needs it. Are we clear? You don't have to wait for 48 hours. So the sooner, the better, correct? All you need is an order. Call your doctor. Hey, patient doesn't need it anymore. Patient's ambulating. Okay. So here are the indications. So we put in Foley's in these circumstances. Patients having any surgery. So let's say involving cystoscopy procedures, okay, because they're bloody and patients cannot void with blood in the bladder. Patient is critically ill. We need to evaluate our treatment and also the patient's overall hemodynamic status because the kidneys are peripheral organs. That means if the kidneys are making enough urine, minimum urine, that means are the kidneys getting blood flow? Yes, they are. Yeah. So meaning if they're making urine, then they must be getting blood flow, right? Okay. So critically ill patients, most patients in ICU, shock patients, bleeding patients, heart attack patients, they get a Foley. Okay, because we want to make sure is cardiac output enough. Does that make sense? Meaning if it reaches a peripheral organ like the kidneys, that means it must have reached central organs as well, correct? Yeah. So patients can't pee. You put in a Foley or at end of life because we're no longer concerned about UTIs at the end of life. We just want the patient to be comfortable. Are they comfortable when they soil themselves constantly? Okay, that's no way to die, right? Next, patient has some nasty wounds and the patient is incontinent. Do you want urine to be in your wounds? Okay. And then relieve urinary obstruction, which is related to urinary retention. Anything else that's not here? Do you have a justification for the Foley to be in there? Does it include nurse doesn't want to deal with incontinence? Is incontinence here? I don't see incontinence here. The patient doesn't want to get up. Is that here? No, it's not. Patient is obese, can't get out of bed. Is it here? No. Okay, so there must be a reason. And what are those reasons? These bullet points here. Are we clear? If it's not here, does the patient get a justified reason for the Foley? No. So if the patient gets a Foley and they have none of these indications and then they get a COTI, will the hospital receive reimbursement? No, because there was no legitimate reason for the Foley in the first place. Yes, sir. Patients who have what? Yes, bedbound patients, you know, they meaning, well, it depends really. If you have evidence of, because when they can't pee, that means the bladder must have distended, right? Meaning the patient already had episode. So yes, now you have a justification. So you documented that the patient had one or more episodes of urinary, bladder distension. Then you inserted a Foley and then we documented, oh, there was 900 or 1200 in there. So yeah, okay, we have a reason. We can't have that, right? So the patient needs a Foley. Did I answer your question? So what's the
No, okay, so technically, if someone comes in and they're in a coma, it's okay to have the hep.
No.
That's what I'm
Again,
trying to
there
figure out.
has to be evidence of urinary retention because even though you're in a coma, you can still pee. Some patients can be, I mean, they'll just pee themselves. In that case, the Foley is not your answer because we have external female catheters. We have external urinary catheters. You have a condom catheter for a male, and then we have the PureWick system, right? Or PrimaFit, that's another brand, right? So we have other non-invasive means. Okay. So if we're incontinent, doesn't mean they have to soil themselves, but because we have external catheters now. Okay, so we've gone, gone a long way. So we've figured out ways to keep them dry. Yes, without a indwelling catheter.
Very low bladder count.
Again, those are patients who will have urinary retention. So yes, that's justified. So same problem with a neurogenic bladder, meaning patient can't pee. The bladders don't contract anymore. Like spinal cord injury patients, let's say paraplegics, yeah, those guys can't pee. Yeah. They have to catheterize. Yes.
A pregnant woman doing the vaginal delivery.
Oh yeah, that's part of surgery right here. Yeah.
Why should, yeah, it was last time, why should they have a fluid catheter? Because she's getting, no, it was bad, she was.
Yeah, because we might injure the bladder because when the gynecologist pushes down on the uterus, the fundus, again, they just don't want to deal with that. And plus they get incontinent during pushing, and they don't want the baby, showering with urine. I mean, just not pretty, right? I mean, you're peeing on your on your on your newborn, Right? Are we clear? All right. So indwelling catheters only placed if necessary, and these are the indications. All right. I think oh no, not yet. We still have two more, and then I'll give you a break. We've got hydronephrosis. Okay, let's do this one. I know what. That's okay. We don't have. Let's do urinary retention and then the complications. Okay. Yes. What was the question? Go ahead.
Oh.
Urinary retention. Okay. So there are many causes of urinary retention. There are neurologic causes, meaning the patient had a spinal cord injury, patient had a stroke, brain trauma, whatever the cause is, which results in the patient's bladder unable to contract and empty. There are also functional reasons, let's say, or physiologic reasons wherein the patient has a enlarged prostate, which is pressing on the urethra or the ureters, whatever the cause is. So it's either obstructive cause or a neurologic cause. Signs and symptoms, obviously the patient cannot pee. So the bladder is large, round, and palpable. The result of a distended bladder is severe hypertension. So consider that when the patient has a really high blood pressure, for instance, and you can't figure out why is this patient's blood pressure so high, check the bladder. Okay, it could be a distended bladder. Let's go to complications. So what could possibly go wrong if your bladder is so full? These are the following. So we know UTIs that can develop. We can also have stones. So either you'll have the stones in the ureters, in the bladder, or going up to the kidneys. We already discussed pyelonephritis that can result from urinary retention because is it acute or chronic? Acute. Okay, acute, yeah. Sepsis, because once you have pyelonephritis, then that could become urosepsis and then sepsis. Or hydronephrosis. Hydronephrosis is a condition wherein the urine was already produced, urine went to the bladder, but then because it can't come out, everything backed up. So the urine returned to the kidneys. Is that supposed to happen? Hydronephrosis can cause chronic kidney disease. All right. Right. So basically your septic tank, okay, the sewer backed up into your bathroom and then flooded your house. That's what hydronephrosis is. You get the picture? Okay, so is it nice to have hydronephrosis? No. Again, this will lead to CKD, chronic kidney disease. So is this an emergency? Yes. So if you have hydronephrosis, if they can't fix the problem, they will have to divert the urine. So they'll take the patient down to radiology. The radiologist will perform insertion of a tube, a nephrostomy tube. So it's CAT scan guided. So they'll insert a tube into one or both kidneys to drain urine. So if it can't come out through the bladder or the urethra, they'll come out through the tube, okay? Relieving the hydronephrosis, saving your kidneys. Okay. Yes, sir. No, meaning they do it under radiology because they need to see which direction to put the tube in. So they just make one small nick, 1 centimeter incision, and then insert the tube. Okay, but they need pictures, okay, to see where is the tube now. Right, under fluoroscopy or ultrasound or CAT scan. All right, so these are your ways to manage urinary retention. Okay, develop a routine urinary avoiding pattern, habit. If you're one of those who like to exercise your bladder by challenging it, seeing how much can my bladder hold. Okay, so you don't want to find out the hard way. Okay, next thing you know, you're already in hydronephrosis, and then you're at risk for losing your kidneys. Okay. So how do we promote urinary elimination? So here are your interventions. Please exhaust these, okay, before you ask for a Foley. Okay, so because not some, but most nurses I know, myself sometimes included, always go to the doctor. We see bladder distension, patient hasn't been peeing for the last 12 hours. What do we ask for? A catheter. Okay, but there are many ways to promote elimination. Okay, so try to avoid a catheter because what's the consequence again when we insert catheters? An infection, especially if we don't do proper perineal care. Or if the patient's incontinent, you can't help it. What are they again? So sitz baths, warm compresses to the perineum or over the bladder, showers, warm showers, caffeine-free beverages. Triggers here, turning on the faucet. What do you guys do at home? Or from the nursing home when you were at the nursing home? You're stroking the abdomen or inner thighs, tapping over the pubic area, dipping patient's hand in warm water. All right. So there are ways to trigger urination. An alternative to long-term indwelling catheterization is, imagine you have a catheter coming out of your penis for 2 years or longer. Right? Or let's say in your urethra for females. okay, coming out through your perineum, yeah, catheter. So if that's the case, some patients in consultation with the doctors, if this is going to be an ongoing chronic thing, they'll be better off with a suprapubic catheter. Has anyone seen a suprapubic catheter? Okay, it's a simple procedure. So it's a short, they can do it at the, well, most cases they'll do it in the OR. But it's a short procedure, 15 minutes, we're finished. Yeah. So here's the bladder. So that's it. They make a small incision. So this is somebody's abdomen, lower abdomen. So this is over the bladder. So they make a small incision, insert the catheter, and there you go. This one's new, that's why there's stitches there. But if it's old, all you see is the catheter, and then the patient forms a stoma. There you go. That's an alternative over the abdomen. Right there. Looks like a second belly button.
That's what they do, right?
Yes, this is going straight to the bladder. Yeah, so this is an alternative rather than having it come out of your penis or your perineum. Because can the patient have sex while having you have a catheter in the penis? No. Okay. So this is a good alternative. That's it. Have a short break.